Guys, so let us start the rapid quick revision of the respiratory medicine. And you know that respiratory medicine begins with the PFT interpretation. And when it comes to PFT, all we are interested as clinicians is the ratio of FEV1 by FVC. So if this ratio is in any respiratory disorder, the investigation of choice for majority of the respiratory disorder is going to be PFT, because it can help us to differentiate between restrictive and obstructive disorder. So we begin by FEV1 by FVC ratio. And if this ratio is less than 0.7, or if expressed in percentage less than 70%, it is always suggestive of obstructive disorder. It is suggestive of obstructive disorder. It could be asthma or COPD, right? But if the ratio is more than 0.7, or in terms of percentage more than 70%, then it is either suggestive of a restrictive disorder or no respiratory disorder at all, right? So if it is more than 0.7, you have to think of what is happening to the FEV1 and FVC. If they are normal, that means there is no respiratory disorder, means the ratio as well as the internal values, that is FEV1 and FVC, are normal, then there is no respiratory disorder at all. But on the other hand, if these values are decreased, FEV1 and FVC are decreased, and ratio is not decreased, like ratio is fair but the values are decreased, ratio also normal, values are also normal, no respiratory disorder. But if ratio is normal but the values FEV1 and FVC are decreased, it is suggestive of restrictive disorder. Restrictive disorder. So when it comes to restrictive disorders, what all come to your mind? We can think about interstitial lung disease, right, where the lungs are fibrosed, then they are restricting the lung expansion. Then pleural effusion and pneumothorax. Pleural effusion, pneumothorax, pneumonia, then chest wall deformities, where the deformed chest wall is restricting the expansion of the lung. Chest wall diseases like kyphoscoliosis or kyphosis. All of these, how do I diagnose once PFT has confirmed that it is restrictive disorder? Go ahead with an imaging, do a HRCT or X-ray. They will be able to identify these abnormalities, or maybe ultrasound, right? Imaging is the next step if it is a restrictive disorder. But if it is obstructive disorder, we have three differential diagnoses: asthma, COPD and bronchiectasis. So how will I differentiate? If it is an obstructive disorder, next step is to go for what we call as bronchodilator reversibility test. So what do we do in bronchodilator reversibility test? We would already know the patient's baseline FEV1, which we have already done for calculation of this ratio. We know the baseline FEV1, and on top of that we will administer a short acting beta agonist, and whatever FEV1 we repeat now after administering the SABA, that FEV1 will be called as post bronchodilator FEV1. And if this post bronchodilator FEV1 increases by more than or equal to 12%, it is suggestive of reversible obstruction. It is suggestive of reversible obstruction. And whenever we have reversible obstruction, we have only one major differential diagnosis, and that is going to be asthma. So any patient where the FEV1 by FVC ratio is less than 0.7, that is obstruction, and I give a beta agonist nebulization or inhaler, and FEV1 jumps by more than or equal to 12%, it is asthma, right? Also note that it's not just about 12% or by an absolute value of 200 ml, more than or equal to 200 ml. So if the jump from pre-bronchodilator to post-bronchodilator 200 ml is that, don't even calculate the ratio. It is reversible obstruction. It is asthma. Simple. Okay. If the ratio increases by 0% or less than 12%, increases by less than 12%, it is suggestive of persistent obstruction. And when we have persistent obstruction, it could be either asthma or COPD. Persistent obstruction is equal to, sorry, not asthma, the COPD or bronchiectasis. Clear? So this is the approach that we are going to follow. This is very, very important, right? Please remember this approach. It begins by looking at FEV1 by FVC ratio. Less than 0.7 is obstructive. More than 0.7, either normal or restrictive. Decide based on FEV1 and FVC values. If everything is normal, it is normal. If FEV1 and FVC values are low but ratio is high, then it is restrictive. Restrictive, go ahead with the imaging, HRCT or X-ray or ultrasound to diagnose further. Obstructive, do what we call as bronchodilator reversibility test. Give a SABA and see how much FEV1 increases after the bronchodilator. If 12% increase or higher or 200 ml increase, then it is asthma. Less than that, it is COPD or bronchiectasis, right? Some extra points to note. There is a entity called as DLCO. DLCO is decreased in COPD, particularly which type of COPD? It is the emphysema type of COPD and interstitial lung diseases, right? I'm giving you an extra MCQ point which I have not discussed in the offline classes. The earliest finding in ILD, even before the X-ray and other like HRCT changes become evident, is decrease in DLCO. Decrease in DLCO is the earliest finding that you can get in patients with ILD. Okay, clear? Okay. Now there is one more possible potential MCQ point that I have not addressed in the offline classes, but it was there in the last ionized CT. How do I diagnose? How do I diagnose asthma when patient is not going through attack? All this ratio that we are talking about low comes when there is an attack. If I do a PFT when patient is not going through asthma attack, it may come normal. In that case, how do I diagnose it? Because that time the PFT will be normal. So asthma diagnosis with normal PFT. We do something called as methacholine challenge. Methacholine challenge. So what we do is we will have the patient's baseline FEV1 and then we will administer methacholine instead of SABA. SABA relieves the bronchoconstriction, but methacholine actually triggers bronchoconstriction. Remember, the parasympathetic nervous system causes bronchoconstriction. Sympathetic causes dilatation. So methacholine is acetylcholine-like. So it causes bronchoconstriction. And then post methacholine FEV1 is what we are looking at. And if decreases by more than or equal to 20%, it is suggestive of airway hyperresponsiveness. Airway hyperresponsiveness, and that is equal to asthma. So basically we are precipitating, we are triggering an asthma attack by giving this methacholine. Okay, this is again an important MCQ point for this upcoming exam, so I want you to remember it. Okay, that's about our basic PFT and its approach. Another point I want you to remember is DLCO can be increased in patients with pulmonary hemorrhage, like Goodpasture's syndrome. Increased in pulmonary hemorrhage. Whenever there is bleeding in the lungs, the DLCO, because carbon dioxide can easily enter into the blood through that bleeding site, we will have high DLCO. Okay, now we will start with the first major disease, that is going to be asthma. Asthma. Okay, key points to remember about asthma is we have different classifications of asthma. Different classification of asthma. So the first classification is based on intrinsic versus extrinsic. We have based on where is the trigger, we have intrinsic asthma and extrinsic asthma. Intrinsic asthma, the trigger is inside the body, usually infections are the trigger, and when it comes to extrinsic asthma, allergies are the trigger. So extrinsic asthma is also called as atopic asthma, right? So trigger for intrinsic asthma is usually infections, but the triggers for extrinsic asthma are allergens. The extrinsic asthma is typically more common in children. It is childhood onset asthma. Extrinsic asthma is childhood onset, and because most of the children outgrow asthma, it is considered as having prognosis to be good. On the other hand, this intrinsic asthma is adulthood onset, and intrinsic asthma carries what you call as Samter's triad. You know the components of Samter's triad. I don't have to reiterate. That is nasal polyp, aspirin hypersensitivity. They have aspirin hypersensitivity and asthma. So asthma, nasal polyps plus aspirin hypersensitivity makes up what you call as Samter's triad. And this adulthood onset intrinsic asthma carries poor prognosis. So this is one way of classification of asthma. There is another classification of asthma which is based on the helper T cell involved in the pathophysiology of asthma. So we have two subclasses. So the first one is type 2 asthma, the second one is non-type 2 asthma. So the type 2 asthma is where the Th2 cells are involved. In non-type 2, it is Th17 and Th1 cells are involved. And which cytokines are involved in the pathogenesis of type 2? Interleukin 4, interleukin 5 and IgE. Here it is interleukin 17, interleukin 1, interleukin 6. These are the cytokines involved. Which effector cell is involved in type 2? In type 2 it is mainly eosinophils. In non-type 2 it is neutrophils. And what are the markers of this type 2 asthma? The markers of type 2 asthma are, number one, you should remember the markers of type 2 asthma. Easy, cost effective is absolute eosinophil count. Higher the eosinophil count, chances that it is type 2 asthma. Then second, increase in the serum IgE levels. And third, increase in fractional exhalation of nitric oxide or FeNO. These are markers of type 2 asthma that you need to remember. Okay, so now that we know the classification of asthma, let us look at clinical features. So just like any other case of obstructive respiratory disorders, these patients present with dyspnea, cough, dyspnea or shortness of breath, and cough, and wheeze as the complaint. And on auscultation, you will hear this wheeze as rhonchi. Okay, that's about the clinical features. When it comes to diagnosis of asthma, you know the diagnosis is based on PFT, right? PFT based diagnosis. PFT is the investigation of choice. What are the findings we are going to get? It is an obstructive disorder with characteristic reversible obstruction. So now you should know what are we expecting when we do the PFT. If there is reversible, if there is obstructive disorder, FEV1 by FVC ratio will be less than 0.7 or less than 70%, and post BDR FEV1 is expected to show more than or equal to 12% or more than or equal to 200 ml increase. That indicates that it is a reversible obstruction. If you are not able to use this, alternatively you can use peak expiratory flow rate as the alternate. But there, if you're using PEFR, you need to have more than or equal to 20% increase in peak expiratory flow rate to call it as reversible obstruction and call it as asthma, right? If it is FEV1, 12%. If it is PEFR, 20%. Once you diagnose it as asthma, for the management, we follow the GINA guidelines. And according to GINA guidelines, we are going to manage every case of asthma. So what GINA guidelines says, patients of asthma are prone for recurrent attacks of asthma, and the attack severity as time progresses goes on increasing. And that's why you don't not only treat an attack, but you might have to think of preventing, because attack severity increases because of the smooth muscle hypertrophy. So we will be using two kinds of medications to treat a case of asthma. What are those? One, reliever, which treats an asthma attack when it is already going on, and a preventive medication. and a preventive medication which is called as maintenance medication. Okay, so what can be considered as a reliever? Anything that acts quickly will be a reliever. So SABA and SAMA are relievers, and for maintenance, LABA and LAMA can be considered as maintenance, and inhaled corticosteroids, because they're anti-inflammatory, they're part of maintenance medication. So among the relievers, SABA is preferred. Among the maintenance, LABA plus ICS is generally preferred. But what guidelines say is, when you are choosing LABA, preferably choose formoterol, because formoterol has an added advantage of rapid onset of action. So it gives you the benefit of SABA as the reliever, and at the same time, it can do the job of LABA because it is long acting. So it does the maintenance as well as relief, and that's why it is now the preferred treatment. So when it comes to the management, remember the preferred treatment is a combination of formoterol plus ICS. Why formoterol? It is rapid onset. So if it is rapid onset, it can relieve, but it is also long acting, so it can prevent, right? So this is a preferred treatment. Now, should I ask every patient to take daily inhalers or only selected patients, right? So for that, we will look at the GINA guidelines. So what GINA guidelines say: if patient is getting 4 attacks of asthma per week or more than 1 nocturnal attack, he requires maintenance treatment. And when maintenance treatment and reliever is combined into one, that is formo, we will call it as MART. So when is MART required? For those patients who get more than or equal to 4 attacks of asthma per week or more than or equal to 1 nocturnal attack of asthma per week. If you don't require that much, then you don't need regular inhalers. As and when there's an attack, you can take a inhaler, right? And if I require MART, then the post bronchodilator FEV1 will decide whether I will start with a low dose MART or whether I will start with medium dose MART. If the post bronchodilator FEV1 is more than 30%, I will start with low dose MART. If it is less than 30% of the predicted value, I will start with medium dose MART. And once we start with a MART, we will follow a step ladder pattern of escalation. What do you mean by step ladder? Based on the situation, we would have started some patients on low dose MART, some on medium dose MART, some on as and when required reliever. We will always step up the treatment to the next stage. So some patients start here. If they're not controlled, they go here. Some patients start here. If not controlled, they go here. Some patients directly start here. Some may come to medium dose MART by crossing all the stages. Some are directly started on medium dose MART depending on the frequency of attacks. But no patient is started on high dose MART. Once medium dose MART fails, we can consider high dose MART or using other biological agents like all the list we have mentioned: omalizumab, dupilumab, mepolizumab, reslizumab, benralizumab, and tazepilumab. Only when medium dose MART has failed, right? So for the management, we are going to follow the GINA guidelines. I'm not writing it down here because it will just consume the time, but you already have it in your workbook, right? So please follow it from workbook. I definitely urge you to solve some MCQs on the GINA guidelines because they keep asking MCQs on it, right? Okay. And then one more MCQ point that I want you to remember is which biological can be used regardless of the type of asthma, whether it is type 2 or non-type 2, and that's only one, tazepilumab, which is anti-TSLP. Everything else depending on the type of asthma, means omalizumab, dupilumab, mepolizumab, reslizumab, and benralizumab are used only for type 2 asthma because IgE, interleukin 4, interleukin 5 are involved only in the pathogenesis of type 2. They are not involved in non-type 2, right? So that completes our discussion on asthma. Now I will take you through, next is COPD. COPD. So what is COPD? It is a chronic respiratory disorder characterized by persistent obstruction. Asthma was characterized by reversible obstruction. This is characterized by persistent obstruction. Okay. Second thing, it is due to chronic exposure to noxious or harmful gases. So now Delhi is also a risk factor for COPD. because you have chronic exposure to noxious gases. The most common cause for COPD, as you know, is smoking. That includes any form of smoking, including the recent e-cigarettes. But the most common cause for COPD in non-smoking females is burning of biomass fuel. Chula, burning of biomass fuel is the most common cause. Genetics, as you know, also plays a role. Genetics particularly increases the risk of developing emphysema. Genetics plays a role in emphysema type of COPD, not in chronic bronchitis, and that is alpha-1 antitrypsin deficiency, right? And in the workbook, you might notice that when we talk about alpha-1 antitrypsin deficiency, it causes an emphysema, which is predominantly alpha-1 antitrypsin deficiency. When it causes emphysema, it predominantly causes pan-acinar emphysema affecting the lower lobes. If smoking causes emphysema, it causes centri-acinar emphysema affecting the upper lobes. So easiest way to remember is think of a smoker. They smoke to feel high, that is upper lobe affected, and inke dimag mein, in their mind, the center of thought is always around when do I get next chance for smoking. So it is centri-acinar. Center of thought process is smoking. In case of alpha-1 antitrypsin deficiency, you get pan-acinar and lower lobe predominant emphysema. Okay. Now, in terms of clinical features, as you know, the COPD patients have two subtypes. One of them is chronic bronchitis. The other one is emphysema. And you know that chronic bronchitis patients are defined as they are also called as blue bloaters. They are called as blue bloaters because in these patients there is hypoxia that causes cyanosis, and hypoxia causes pulmonary vasoconstriction, increase the risk of cor pulmonale. So these patients have cyanosis and they are at risk of developing right heart failure called as cor pulmonale. And in these patients, how do you define or how do you recognize that this patient is having chronic bronchitis if there is history of smoking? More than or equal to 3 months of productive cough per year. 3 months of productive cough means cough with sputum per year for 2 sequential or consecutive years. 2 sequential or consecutive years. That's how we define chronic bronchitis. And cor pulmonale is one of the cause for death. In fact, it is the second most common cause for death in COPD. The most common cause is still coronary artery disease, right? Cor pulmonale is the second most common cause for death. Okay. Now, when it comes to emphysema, what problems these patients will have? Emphysema is defined, these people are called as pink puffers because here there is irreversible dilatation of the acini. So it is defined as irreversible dilatation of acini. Dilatation of acini. And because the acini are dilated, the volume of acini is increased. So air easily comes. Volume increase means pressure low. So in the acini, air easily comes into it. But leaving the acini for the air to go back to the atmosphere becomes difficult because they're irreversibly dilated. They cannot recoil back. So it leads to air trapping in the lungs. And because of this air trapping, now the lung volume starts expanding. To accommodate this expanding lung, the chest wall becomes barrel-shaped. Barrel-shaped chest. Now these patients start struggling to exhale the air out. To make it easy to exhale the air out or to increase the pressure inside these irreversibly dilated acini, they do some physical changes. One of that is tripod positioning. When they do tripod positioning, the contracted diaphragm pushes the lung up and makes the lung compress. So this irreversibly dilated acini also get compressed and air from there starts leaving out easily. So they achieve tripod position. Apart from that, they also get something called as, they do pursing of the lips, pursed lip breathing. Pursing also increases intra airway pressure, helps you to exhale easily. So pursed lip breathing. And because of this tripod position, they are repeatedly resting their elbows on the thighs, and that becomes hyperpigmented, and we will call it as Dahl's sign or Dahl sign. In severe COPD patients, if it is severe COPD patients, the intercostal spaces may retract during the inspiration. Normally they don't retract, but here they retract. We will call it as Hoover's sign. Hoover's sign. Remember in the offline class I had told you intercostal space indrawing during inspiration. I is what we call as Hoover's sign. Another extra point that was asked in the last INI-CD that I want you to remember is in the emphysema variants is where DLCO is decreased. The DLCO is not decreased in patients with the chronic bronchitis. It is the emphysema patients where you see the decrease in DLCO. So they can ask you who is prone for cor pulmonale. It is the chronic bronchitis, and because of the cor pulmonale they have edema. That's why they're called as bloaters, right? Okay. Now when it comes to the COPD diagnosis, it will be PFT based. So PFT will show FEV1 by FVC ratio of less than 0.7, and which is suggestive of obstruction. But when we do the BDR and post BDR FEV1 is checked, it shows less than 12% increase, suggestive of persistent obstruction. If you're looking at the PFR instead of the FEV1, then less than 20% increase. Okay, apart from that, if you do chest X-ray, you will see flattened diaphragm, tubular heart, widened rib spaces, and darker lung fields. These are classical findings of emphysema. I don't expect an image-based questions as such on that. So once you diagnose it as COPD, when it comes to the management of a case of COPD, we will be following GOLD guidelines. Okay. So now I will be taking another week's time to give you the 2026 GOLD guidelines. 2026 guidelines, because the guidelines are updated well in time. Generally they come in the month of January. This time they have updated it early, and there are potential MCQs possible. So don't right now bother about the GOLD guidelines that you have studied in the offline classes. The things might have changed. I will give you an update on it in a week's time, because even I need to study what all changes they have made. For now, just stick to your study till the diagnosis, right? That's about COPD. Extra points I want you to know with respect to COPD is indications for long-term oxygen therapy. What are the indications for long-term oxygen therapy? If the patient has SpO2 less than 88%, or if the SpO2 is less than 89% with evidence of right heart involvement. If patient has right ventricular hypertrophy, increased erythropoietin, or if the patient has pulmonary hypertension. And what is the advantage of this long-term oxygen therapy? It decreases COPD mortality. It is the only intervention or treatment that decreases COPD mortality, apart from, yes, smoking cessation. Okay. And then they may also ask indications for a procedure called as lung volume reduction surgery. It is done for patients with upper lobe predominant emphysema. That emphysema, if it is up in the upper lobe, we can chop that lobe off. We will call it as lung volume reduction surgery. So which patients are most likely to benefit? It is the patients with smoking, because smoking causes upper lobe predominant emphysema. Alpha-1 antitrypsin deficiency causes lower lobe predominant emphysema, right? So these are the important points that I want you to remember for COPD. Okay. Now let me take you through the next important topic from the respiratory medicine, which is going to be interstitial lung diseases. So in the workbook, you have a classification of ILDs into known causes and unknown causes. Please go through that. Majority of the questions that are going to come on idiopathic pulmonary fibrosis. There are other rare ILDs which are not considered important for FMG, so I don't want you to waste your energy. Worst case scenario, if they ask, you still be able to predict that it is ILD based on key features. Okay. So when it comes to ILD, the two things I want you to remember is idiopathic pulmonary fibrosis, This is the most common ILD, typically seen in elderly after 50 years, smokers, elderly smokers, that too males, elderly smokers, that too males. And the risk factors, apart from being elderly, being smoker, and being smoker, there is also genetic contribution to the risk, mainly mutation in MUC or mucin 5b, which is coding for mucin, and telomere regulators, TERT, those kind of genes, telomere regulator genes called TERT and TERK. Okay, now what clinical features these patients present? Just like any other case of respiratory disorder, they also present with cough, which is usually dry, and shortness of breath. So on examination in these patients, like in COPD and asthma, we get wheeze or rhonchi. Here we get end inspiratory fine end inspiratory crackles, and these crackles are also described as so-called Velcro crackles. And remember, Velcro crackles, if it appears in any of your MCQs, examiner is pointing towards idiopathic pulmonary fibrosis. And when I have to diagnose these patients, for diagnosis, I go ahead with HRCT. HRCT is the investigation of choice. If you do PFT, ILD is a restrictive disorder, so you get this classical restrictive pattern. And I have already told you, once you have restrictive pattern, you go ahead with the imaging, and imaging modality of choice here is going to be HRCT. What do I get in HRCT in idiopathic pulmonary fibrosis? I get what is called as UIP pattern. And what is there in UIP pattern? Predominantly you have honeycomb changes. Honeycomb changes because of extensive traction bronchiectasis. Honeycomb changes. The word honeycomb appears in any HRCT image related question. It is talking about idiopathic pulmonary fibrosis. Once you diagnose it as IPF, how are you going to manage a case of IPF? The management primarily focuses on, first line treatment is antifibrotic drugs. Antifibrotic drugs. So what all comes under this antifibrotic drugs? First we have is perfenidone, and the second one is nintedanib. So as second line treatment, you can think of immunosuppressants. But if they also fail, these patients may require, as last ditch effort, if possible, lung transplantation. Okay, now we have one more ILD, that is idiopathic non-specific interstitial pneumonia. And you remember from the offline classes, you have to think of exactly opposite of IPF. IPF was typically more common in elderly male smokers. This is more common in young female non-smokers. Here patients in terms of clinical features, same, cough which is dry, and shortness of breath or a dyspnea. On examination, here also you get fine crackles. And for diagnosis, we go for the HRCT, which is the investigation of choice. Here also ILDs, all ILDs are restrictive disorders, so PFT will show restrictive pattern. Here HRCT shows something called as NSIP pattern, non-specific interstitial pneumonia pattern. And what do you get here? You get extensive ground glass opacities. You may have traction bronchiectasis, but not sufficient enough to cause what you call as honeycomb. So the word honeycomb points towards UIP pattern and IPF, and word ground glass opacities points towards NSIP pattern. Okay, and when it comes to management, the first line is usually steroids, and second line is going to be immunosuppressants. This is not generally going to be as bad as a case of IPF. So NSIP generally carries NSIP has better prognosis than idiopathic pulmonary fibrosis. And as I always say, males are unlucky because males get usually IPF, which carries poor prognosis. Females get NSIP, which generally carries better prognosis. Right? That's it about our interstitial lung diseases. Right? I will address one more topic here, which is going to be respiratory failure. So the fourth topic we are discussing is respiratory failure. So what is respiratory failure? Impaired oxygenation or impaired carbon dioxide clearance. And the investigation of choice for diagnosis of respiratory failure is going to be ABG. So when you do ABG, how do I interpret it to diagnose whether I have type 1 or type 2 or different types of respiratory failure? So when you do ABG, the first thing you should see is PaCO2. If PaCO2 is increased, that means there is impaired carbon dioxide clearance. It means it is type 2 respiratory failure. But if PaCO2 is not increased, and when I say not increased, it means either normal or even decreased. It is not increased. If it is not increased, it could be type 1 or it could be normal. So what I should do then? After that, I should see the PaO2. If the partial pressure of oxygen is decreased, carbon dioxide is not increased, but oxygen is decreased, then it is type 1 respiratory failure. Type 1 respiratory failure. So type 2 respiratory failure is also called as hypercapnic or hypercarbic respiratory failure. Hypercapnic respiratory failure. Type 1 is also called as hypoxic respiratory failure. Hypoxic respiratory failure. If the PaO2 is not decreased, it could be normal or high, whatever. If it is not decreased, what does it indicate? Neither your carbon dioxide is high nor oxygen is low. Means there is no respiratory failure. There is no respiratory failure. Simple, right? Now MCQ wise they will ask you what is the most common cause for the type 2 respiratory failure. The most common cause for type 2 respiratory failure is COPD. The most common cause for type 1 respiratory failure is pneumonia. Then they will ask you what is the first line treatment. The first line treatment for the type 1 respiratory failure. Low oxygen. So what is going to be the first line treatment? Give oxygen. But in COPD, carbon dioxide clearance is a problem. So I need to increase the intra-acinar pressure so that carbon dioxide comes out. And how do I achieve that? I achieve that through NIV. So the first line treatment for the type 2 respiratory failure is going to be non-invasive ventilation. To be more precise, the BiPAP type of non-invasive ventilation, right? That is type 2. Now, only thing is there are two subtypes of these respiratory failure. Type 3. Type 3 is any type of respiratory failure that occurs in any type. Type 1 could be, it could be type 2 in peri or post-operative period. And what is the reason for it? Due to atelectasis or collapse of the lungs. And what is type 4? Type 4 is any type of respiratory failure in patients with shock. So the key point to remember: atelectasis, peri-post-operative period, shock. Why these are two separate categories? I have discussed that at length in the offline classes. I will just write down the key point. The first line treatment for type 2 respiratory failure is going to be incentive spirometry. Doctors should not unnecessarily use oxygen or waste oxygen and become a cost burden to the patient. Try incentive spirometry. But if it is type 4 respiratory failure, don't try oxygen, NIV and all. These patients require mechanical ventilation. Right. So that's about the respiratory failure. So we have addressed asthma, COPD, ILDs and respiratory failure. Another important topic from the respiratory medicine is going to be pleural effusion. Please go through that from the workbook. Apart from that, yes, ABG, not a respiratory topic primarily, from the nephro part. ABG is an important topic. If you want, let me know. You can just reach out to me through the Instagram. If you want these topics, I will definitely share a recording and you can go through even the interpretation of ABG. The worst case scenario, I mean, ABG, there's always one question. most of the times it's a straightforward question. Worst case scenario, what they've asked is anion gap calculation. Questions beyond that are usually rarely encountered in FMG, but now you know the exam trend is changing, so they may go beyond that anion gap and they start asking you about delta gap, partial compensation, full compensation and all. If you want a video on that, let me know. I will record and share. It will be of a 40-minute video where you will learn everything related to APG. That's it from me on the revision video modules. Please give the upcoming test, and I will be connecting with you live again to discuss the questions. I will be adding few more critical topics which we have not covered in the offline classes, but in the recent exams, especially INI and NEET PG, they have started asking questions, so they've started touching these topics. There will be some questions based on that. If you can answer, good. If not, don't take it to heart. Anyway, I'll come and discuss them in the discussion session, right? That's it from me now. I'll be signing off. See you in the test and discussion. Till then, have a good time.